Hello, we are live. All right.
All right. Hi, good evening, everyone. Welcome to the fourth Posi webinar. And we are honored to have with us Dr. Salil Upasni from Rady Children's Hospital, San Diego. And he's the hip guy in San Diego now and has got a lot of experience working with Perthes disease as well as syphilis and all kind of complex hip reconstructions
In San Diego now and has got a lot of experience working with Perthes disease.
So let me hand over to Salil to start his talk on current concepts in management of leg calf Perthes disease. Over to you, Salil.
Wonderful. Thank you. Thank you, Sandeep. So I'll try to keep this talk interactive. I have some cases built into it, so I'd love to get our esteemed panel involved. We have Mandar, Manoj, and Venkat, who are going to join me in discussing some of these cases. So as you know, leg calf Perthes disease was described back in 1910. The goal of the talk today is to present some of the current concepts and thought process and how we approach these patients. So before we start talking about Perthes, unfortunately, we need to go back to our medical textbooks and think about bone biology and the different stages of endochondral ossification. So I think this figure kind of presents that process very nicely in that we're starting with a structure of hyaline cartilage where the cartilage starts to deteriorate and we have a blood vessel that penetrates into that region. And that's what allows the cartilage chondrocytes to turn into osteocytes and form bone, especially as can be seen in that secondary ossification center. So with Perthes, it's kind of a reversal of that process. So either due to hypoxia, where the actual blood flow has stopped, and or due to strain. So strain would be repetitive loading, excessive motion, chondrocytes or cartilage tissue prefers an environment of hypoxia and strain as opposed to osteocytes and bone. So there's a reversal of that endochondral ossification process where the bone turns back into cartilage for a short period of time and then proceeds through its healing stages. So this figure by Harry Kim, published in JAOS 2012, it's a wonderful review article. But I think these concepts presented by Jonathan Schenecker add a lot to our understanding. So in terms of looking at states of avascular necrosis or of hypoxia, we can look at Perthes disease as fitting in between common DDH as well as SCFE or slip capital femoral epiphysis. So we all know that if young kids get avascular necrosis in either our treatment of DDH or due to proximal femoral growth disturbance, there is usually a great restitution of that spherical femoral head. And so you get a relatively normal hip joint at older stages, as opposed to SCFE, where that hypoxic state leads to creeping substitution. If you get avascular necrosis in SCFE, that usually results in total hip arthroplasty. So Perthes kind of falls within that spectrum. So if you get Perthes at a young age, you usually get very good femoral anatomy, as opposed to if you get it at an older age, you get lifelong kind of devastating changes inside of the joint. So now if we look at the different stages of Perthes in terms of sclerosis, fragmentation, and reossification, we need to think about what's happening to that femoral epiphysis in those different stages. So stage 1 and 2, the patient is in a stage of hypoxia. So the bone is getting resorbed. And usually what's happening in stage 2 is that there's this metaplasia chondrification. So not only is the bone getting resorbed, but it's getting replaced by the chondrocytes and cartilage cells. We've all seen patients with x-rays like this on the left. And if you do a surgical hip dislocation on this patient, you know that there is a large amount of cartilage that's filling that space that you're seeing on the AP pelvis radiograph. So what are the primary problems with Perthes disease? I think these three kind of simplify the disease. There's deformation of the femoral head. There's a physeal bar that forms across the proximal femoral physis, resulting in its secondary changes, as well as hip subluxation, usually thought to be due to inflammation within the hip joint. So if you look at the deformation of the femoral head, that's usually thought to be due to weight bearing. So when the bone gets reformed into cartilage and you're starting to put pressures through the cartilage, you get deformation of the femoral head. And again, in these figures by Jonathan Schenecker, you see that the body is trying to reossify again. So bringing in hydroxyapatite, bringing in VEGF and BMP2, but loading during this stage when the head is soft and cartilaginous, it results causes the head to become elliptical and start to extrude out of the acetabulum. In terms of physeal bar formation, what's happening is that instead of the chondrocytes getting vascularized, turning back into bone, the vascularization is coming from the metaphysis across the physis into the epiphysis. So as it crosses the physis, it forms a bar, and that can result in high trochanter, it can result in coxa magna, and it can result in coxa breva or short femoral neck. And then the hip subluxation, so there's one part is the extrusion of the femoral epiphysis from the flattening, but also the increased hyperplasia of the synovium, as well as inflammation inside of the hip joint, causing the femoral head to be subluxated or lateralized within the acetabulum, resulting in the secondary changes and this terrible biconcave femoral head that can be seen. So in terms of how we treat Perthes, as orthopedists, containment is still our primary modality. I'm going to cover some of the biologics that have been considered, such as BMPs and bisphosphonates later on in the presentation. But I think containment still works. It's been kind of the gold standard that's been around for a long time. We use the acetabulum to serve as a mold to keep the head round as it goes through its stages of healing. We know that young patients have better biologic plasticity. So in general, we get better Stuhlberg results when the patient gets Perthes at a younger age. And we know that containment improves the sphericity of the head. So Salter has been kind of working with these concepts as well as Tureta since the 50s and 60s. And we understand this concept of containment. So in terms of how we approach patients with Perthes at Rady Children's Hospital, this slide kind of figuratively describes our thought process. So the work by Professor Joseph with the modified Elizabethtown classification, I think, is extremely important. And then we basically put patients on this clock looking at preventative treatment, remedial treatment, and salvage treatment. So basically early on in the disease, when the femoral head is still round, we have certain approaches, which I'll go into. When the head has lost its sphericity and we're in the remedial stage where we use the biologic plasticity of the femoral head and the acetabulum to help remodel the head, we're in that yellow phase, and then salvage treatments, which we'll go into at the end of the talk, when the head has started to ossify or is already ossified in a non-spherical position. So besides the stages that the disease is in, we're also looking at some of these risk factors. We all know that older patients don't do well. So usually this 8-year-old cutoff, which the Dallas, Texas Scottish Rite group helped us define Herring classification. So patients with a flattened lateral pillar are definitely at higher risk for worse results. When the entire epiphysis is involved, when there's subluxation of the hip, when there's avascular or osteonecrosis of the metaphysis, and then in an extremely stiff, inflamed hip where you don't have good abduction, all of those are variables that you know lead to bad results. So I wanted to touch on this work by Harry Kim looking at perfusion MRIs. I think this has really kind of changed the way I approach these patients. And I know some of these tests might not be readily available in India, but I think they provide a lot of information. And just some of the figures from his paper looking at different areas of the epiphysis that are perfused. So this patient had 94% of his whole epiphysis perfused, as well as 94% of his lateral pillar. So we use this technique to define what amount of the entire epiphysis, as well as what amount of the lateral third has blood flow to it in an ability to predict where this patient will end up in terms of the Herring classification. So this patient has 65% perfusion of the entire epiphysis, um, and this patient has 40% perfusion. So basically being able to predict how much of the epiphysis is involved and where the destruction that we're going to see it happening. So in terms of serial perfusion MRIs, early on when Harry started doing these tests, he would follow the patient throughout their disease course. This has kind of lost favor now because of the thought that these agents get um, deposited into the brain and different organs and could lead to um, issues down the road. So we no longer perform serial perfusion MRIs, but I think that one data point when you're first starting to treat the patient is extremely important in terms of guiding which of these paths you're going to go down. So I'll start off real quick by talking about non-surgical treatments. I think the ideal candidate for non-surgical management is someone who's young, so less than 8, someone who's early in the disease, so stage 1A, 1B, or 2A in the modified Elizabethtown. So what that is before fragmentation has started. 2A is early fragmentation, so you're just starting to see the first crack in the femoral epiphysis. Someone who's going to be lateral pillar B. So my issue with the Herring classification is that you can't really define where a patient is going to end up on that classification until the late stages of fragmentation. So unless if you have this perfusion MRI, which can help you predict where they'll end up, most of the time, by the time you know what Herring classification they are, it's pretty far along in the disease, as well as patients who have more than 60% of the epiphysis perfused. So what are different strategies? We've used all of these for a number of years. So non-weight bearing. We know that weight bearing causes deformation of the femoral head. So strategies to keep kids off of their hips would be ideal. When I was in Dallas, they showed some videos of kids that were rolling around on carts and wheelbarrows, all these types of strategies to just keep them from putting pressure onto the hips. Physical therapy to maintain abduction so that the femoral head remains tucked into the acetabulum, as well as using Botox. So I don't know if this has gained favor in India, and maybe this is something we can talk about for our first case. But putting Botox into the adductors helps paralyze those muscles, helps maintain abduction, and could be a strategy for non-surgical treatment of Perthes, as well as casts and bracing. So this is the first case. I'd like to invite Mandar to help me discuss this case. So this is a 7-year-old male. You can see involvement of his left hip. He's in stage 2A. If you can see my marker on the screen, you can see this first line of fragmentation
Yeah.
starting. And then the MRI shows that 60% of the head is perfused. You can see the lateral pillar is preserved. So I'm assuming that it's going to be a Herring A patient.
Yeah.
Mandar, how would you approach this patient?
Yeah. So he's a young kid. It's exactly at the borderline of 7 years, an early stage Perthes disease with a fairly good vascularity. He seems to be a good candidate for non-surgical management, but again, non-surgical management is a very wide group. You said about something about non-weight bearing. Now, non-weight bearing, to ensure non-weight bearing in a healthy, playful 7-year-old kid who doesn't have much of pain is something which is very, very difficult to ensure.
Yeah.
So the one thing which we always had a doubt about is exactly what do you do when you are advising conservative management for a child with Perthes?
Yes. Yes. So just in a few slides, I'll show what the San Diego version of non-operative treatment looks like. So it's different in different centers.
Okay.
So yeah, this patient was treated conservatively. Basically, the main goals are to maintain abduction, maintain hip motion. So here he is 6 months after, 12 months after, you can see he's gone into reossification and
Yeah.
at 18 months after. So relatively spherical femoral head. You can see the
Yeah.
central area of necrosis still, and I'll present a case of that down the road.
Yeah.
So kind of the traditional ways of conservative treatment would be starting with a Petri cast, because I think that's kind of our introduction of the patient and his parents into this concept of treating Perthes. So they need to understand that it's a very serious disease. It can lead to morbidity, and putting patients into Petri cast just kind of reorients the family or prepares them for the treatment that's ahead.
Okay.
So obviously the St. Louis method, I'm sure some of you have visited Perry Schenecker. This treatment definitely works. What they start off with is obtaining motion by doing an adductor tenotomy, immobilizing them in a cast, a Petri cast, and then transitioning them to this A-frame, which maintains the hips and abduction internal rotation. My thought is once these hips are contained, they're able to weight bear through it. And I completely agree with you, Mandar. It's very hard to tell a patient to not weight bear, especially at 5, 6, 7 years of age.
Yeah.
So I think this is a safe way of weight bearing because it's keeping the head contained. And
Okay.
this is their classic study from 2013 showing that they had 93% Stuhlberg 1, 2s, and 3s, but they've braced the patients for a very long
For a
time,
year.
up to 3 years.
Yeah.
So basically throughout their disease, they're keeping them braced and it can work. So our version of non-operative treatment is basically maintaining motion. Fortunately, we have access to outdoor activity throughout the year.
Yeah.
So lots of swimming, lots of physical therapy. If we're starting to get tightness in terms of abduction, we take them to the operating room for a tenotomy, for a medial capsulotomy. So this is a concept
Yeah.
introduced to me by Julian Aguilar from the Philippines. And I think it's a extremely good way of maintaining abduction
Yeah.
because you're not just loosening up the abductor muscles, you're also loosening up the medial capsule, which can be tightened. And
Yeah.
when you do that capsulotomy, it gives you a chance to drain the hip. You can take out some of the synovium inflammation that's present inside the acetabulum, so the pulvinar region, and keep them casted for 6 weeks after that procedure. So it lets the hip calm down.
Yeah.
And I think in terms of getting recurrent tightness, going through this process, I think really helps to preserve that abduction motion.
Yeah.
And then I usually do abduction bracing only at night. So we create a very
Okay.
similar A-frame brace. We keep the patients in it at night. And then during the day, we tell the family to just not get them involved in excessive activities like
Yeah.
gymnastics or
High
football or
impact sports or
running.
something of that sort.
Exactly. Yeah. How about you guys? What does non-op in Mumbai look like?
Yeah, something similar to this. We as you said, the main important thing is to maintain abduction and I maintain range of motion. The problem sometimes comes when there is significant stiffness which continues for a long time, and that is the thing which we wanted to ask you about. What do you do for hips which remain stiff for a long time in spite of your sort of conservative operative methods, the adductor tenotomy with the medial release and with Petri casting and something of that sort?
Yeah. So you've had continued stiffness despite a capsulotomy. I
Yeah.
think that might be the factor. You've done the capsulotomy and it's still
Yes,
tight.
yes, they're still tight, or they become recurrently tight as they go on.
Yeah. So that was my experience. If I only did the adductor, it's common to only do the longest because it's the most
Okay.
common tendon.
Yeah.
And I had patients get recurrent stiffness after that procedure. And so I've started to just do this entire, the adductor longus, brevis, gracilis, and the medial capsule. And
Okay.
I really haven't had stiffness
Stiffness.
recurse.
Okay.
Yeah. Yeah. As long as they're compliant with the nighttime bracing as well.
In
So
India, we ask them to sit cross-legged, which is an added bonus
Yes.
for
Yes.
flexion,
yes,
abduction, external rotation.
absolutely. Yeah. So that'd be a good way to maintain. Have you started using Botox for that
Not yet.
additional? Yeah. Is that performed by the orthopedists or
Yes.
by the rehab
So
physicians?
no. So Botox is still under the purview of the pediatric orthopedic surgeons till now.
Yeah. Yeah.
And it's in fact seems a good idea, but though there's no spasticity here, the muscles are in significant spasm. Must be a
Yeah.
painful spasm.
So at this moment, Salil, let me ask you: are you injecting zolandric acid into the head? Young kid, you're doing the adductor tenotomy, he's under anesthesia, and there are people who are saying, let's reduce the osteoclastic activity by putting something into the head.
Yeah.
How
I'm
does it
not.
work out for you, and do you have any experience or literature?
Yeah, so there's a really good review, which I'll cover later on, where Harry and David Little looked at these treatments. So for me, I haven't started doing it. I'm waiting for more clinical data to show it. Conceptually, it doesn't make sense to me because it's blocking VEGF. And the whole
Yeah.
goal of our treatment is to allow that head to revascularize. And I'm sure there'll be people on this webinar that have had good experience with it. And on one hand, it makes sense because it's slowing down the osteoclast, allowing the osteoblast to work, but it's also blocking the blood supply. So to me, I'm not ready to jump onto that bandwagon yet, but I'd love to see more clinical as well as basic science data to prove that it works.
Yeah, there is a question from audience. What is the right time to perform a perfusion MRI? And does perfusion percentage get worse over time if you do serial MRIs?
Yeah, so I think the right time is before the patient has entered into reossification. So I'm not sure when most often see these patients. For me, they present about 2 or 3 months into the disease, oftentimes before they've entered into fragmentation. So that's, for me, the best time because it can help predict the course of the disease by quantifying how much of the epiphysis and the lateral pillar is involved.
Right,
In terms of serial MRIs, depending on when you're catching the disease, because if it's, it's going, I don't think it's a one-time hit where the blood vessels are affected and it's, so I think it is a course. Sometimes you're going to catch it where it's getting worse. Sometimes on those serials, they got better.
right.
So I think it's when on the disease course you do the MRI.
Okay,
So basically you're getting a snapshot for a disease course, which isn't ideal, but at
right.
least it gives you
A
a
direction.
window into what's happening in the hip. Yeah.
Do you have
Here,
something like a home traction program or something of that sort for relieving the spasm or something of that sort?
no, we don't. We don't do home traction. We just
Okay.
do physical therapy home exercise program. Um,
Okay.
yeah. So in terms
The
of surgical treatment, we'll keep going, and then we have some more cases for discussion. This is kind of the gold standard study that everyone looks at. It was the first the first version of International Perthes Study Group that was created at Texas Scottish Rite. Uh, Data published in 2004, looking at 5 different treatment groups. 51% had Stuhlberg 1 or 2, 50% had 3, 4s, and 5s. So that Stuhlberg 3 group is obviously very interesting. Do we call that a good result or a bad result? Some of those patients end up doing fine. This study was different from Perry Scheneker's that put Stuhlberg 3 into that good group. And basically, they defined that patients who are Herring B or BC over 8 years of age were helped by surgery, and patients less than 8 or type C had no benefit. Basically, less than 8, they all did great with or without surgery. Type C all did terrible with or without surgery. So their conclusion was that surgery was not useful in that patient population. So in terms of how we look at it, now we're entering into that preventative stage. Before the head loses its sphericity, there's smaller interventions that you could do. And in my mind, the 3 smaller interventions are a femoral VDRO, a Salter osteotomy, or a shelf acetabuloplasty. Honestly, I've looked at the published data for all 3 of these, and I think all 3 are extremely equivalent. So whichever one you have the most experience with, I would recommend the surgeon to perform that procedure. I think the best indications for these procedures are, again, early stage 1A, 1B, 2A, young patients less than 8, and unable to maintain motion. So I think maybe where Mandar was going, when non-operative treatment fails, and we're still into these early stages, I think I would follow one of these 3 paths, either VDRO, Salter, or shelf. So again, Professor Joseph has tons of experience with the VDRO, lots of good data coming out of India. I think a very important point that I learned from this, because my early VDROs always ended up with limited abduction from impingement of the greater trochanter in the long term. And I think his technique of putting a screw through that greater troch apophysis might be part of what resulted in such good outcomes in this paper. But there's also good data published out of Norway with WIG, with 368 cases of femoral osteotomy with good outcomes at 5-year follow-up. So here's another case. Maybe Manoj could help me with this case. So an 8.5-year-old male, right hip pain, femoral head extrusion of about 20% on that AP pelvis X-ray. Here's his perfusion MRI. So basically just 40% perfusion affected. And you can see that lateral pillar is preserved. This is what his arthrogram looks like with the abduction internal rotation view. What does this what does this image help you with, Manoj?
So this actually shows that the femoral head sits in quite well within the acetabulum. So it's nice, concentrically seated, that it's sitting under the, there is the lateral portion is well seated within the acetabulum. And given the patient's age, more than 8 years old, early stage, the extent of involvement, the level of perfusion, confirming that. So this confirms that this hip would do very well with containment. That you're able to see it very well. There's no medial dipooling. It's seated concentrically quite well.
Yeah, so this is actually a good way for me to figure out how much varus I'm going to do in the procedure. So you're doing this abduction motion until you see the head get contained within the labrum, and that will tell you how many degrees of varus you're going to put this hip in.
Okay, Salil, there is a couple of questions from Taral. He's asking whether anti-inflammatories have any role.
Yeah, so I think they have a role for two reasons. So the inflammation is part of what's causing the subluxation, so it helps to decrease the swelling in the joint, decrease the fluid to try to keep the head more centered. And it also helps in terms of preserving motion because it's less painful for the child to abduct. So, and then
if you have a younger child where your radiology is Elizabethtown 1B, 2A, but your perfusion MRI says about 30 to 40%.
Yeah.
Does your approach still remain conservative, or you would be a little more aggressive with surgery?
So I think this patient was very similar to that early stage, but bad perfusion. So I would be a little more aggressive, partly because of his age, but also because of the perfusion. So I would try to keep him contained with surgery rather than prolong non-operative treatment.
And if you need more than 30 to 40 degrees of abduction, do you do that much varicization, or would you
that's a good
plan?
question. No, so yeah. Initially, I think I would have done that much and then planned for a valgus osteotomy after the patient is finished healing. So that's one approach. Another approach would be to address it on the acetabular side. So again, if you're able to contain it, you could do a shelf acetabuloplasty at that point, because you don't want to put that much varus into the hip. So there's
We've seen that it doesn't remodel if too much varus is done.
I agree. Yeah. And do you use the straight plate like Professor Joseph shows?
Yes.
At some age, I don't think you're really affecting the growth of the greater trochanter. Manoj, when do you think that apophysiodesis works?
I think it's a little bit hit and miss. When you plan a trochanteric epiphysiodesis, it often doesn't work. So I think age is a cutoff for that. So I think above 8 trochanteric epiphysiodesis, when you do an elective trochanteric epiphysiodesis, I don't know how effective that is. So you really need to watch out how much varus you put in and get the trochanter high up. So up to 8, probably you are like, you're safe.
Yeah, so for a patient treated with a VDR, this is kind of how I would like the x-ray. So we use blade plates, obviously, more than the straight plates. I really wouldn't want the troch to be higher than the joint level, so it's never going to be centered on the center of the femoral head. It's always going to be above that. And I agree with you. I haven't seen any of these remodel, unlike the publication. So this is him at 3 years post-op. It works in some patients that you're able to keep that head contained. So, but obviously everyone has seen this with a leg length discrepancy, permanent limp from that coxivera, and a very good quote from Christoph Meyer saying that for a disease that causes varus, it's kind of ridiculous that we're adding in varus. So that's where treating from the acetabular side, that's where those concepts make sense. So the pure Salter inanimate osteotomy, this is a good result for a patient treated with a Salter. One of Dr. Wenger's cases with 10 years of follow-up. But there's lots of good long-term published outcomes for the Salter osteotomy, as well as the shelf acetabuloplasty. So I really don't have a personal bias towards any of these. Whichever surgery that you're most comfortable with, I think works in this stage for preventing, preventing deformity in the femoral head. I think if you're going to try to do a Salter in the late stages, I don't think that's going to work. When you're starting to have ossification of the head, I don't think it's possible to keep that head contained and keep it spherical. So now we're going to enter into the remedial stages. So a little bit more surgery for patients who are in this group, so stage 2B or stage 3A, or patients with a number of the risk factors or risk signs that we talked about earlier in the talk, or in older patients, so over 8 years of age. So this original publication from Staley looking at Salter plus Varus in Perthes patients, I think it makes sense for more severe disease to try to keep the head contained, but I've seen lots of cases like this too. This is another one of Dr. Wenger's long-term outcomes. Just very, very little room left for the abductors, and requiring a valgus osteotomy to deal with that kind of over containment that you can get with those procedures. So I think the triple innominate osteotomy works very well in this particular instance. This is the original triple described by Steele in 1973. You can see the differences where this ischial cut is, which is medial to the ischial tuberosity, which results in less free rotation and increased risk of pseudarthrosis. This is another approach, this is how Steele had originally described it, with a transverse incision at the buttocks. Tonus then described his triple, the difference again being this ischial cut. It's going above the sacrospinous ligament, which results in better rotation, better coverage, but the obvious risk is that that cut is very close to the sciatic nerve, and it usually requires a separate posterior incision where you can visualize the nerve to make that cut. So in San Diego, we prefer to do this, the Carlios triple. So this ischial cut is very close to where Gonz's periacetabular osteotomy cut is, just inferior to the joint, but it's coming out below the sacrospinous ligament. So you can see that here on the side view. So less risk to the sciatic nerve. This can either be done with a 2-incision triple, so that second incision is in the groin, and you can get to the ischium in between the abductor brevis and the magnus, or you could do that third transverse incision to directly visualize the ischium. So this is a third case. If Venkat could comment on this case. So older patient now, 9-year-old female. My approach was obviously triple, but I'd love to hear your thoughts on how you would approach this case and how you would treat this patient. So these are her initial x-rays. You can see the MRI showing whole head involvement. And some of the risk signs that we talked about in terms of subluxation, a large metaphyseal area of necrosis, and then later stage of fragmentation.
Looks like later stage of fragmentation. It's like in the margin of 2B versus 3A. We don't see any new bone formation on the lateral side.
Correct.
Yes. I personally prefer to do a video here. I think most of the panelists will be doing a femoral side procedure rather than acetabular procedures for this patient. So we routinely do VDO. Even at this stage, if you need a little more of varus, I don't hesitate to do that along with the trochanteric epiphysiosis. Though Manoj said that more than 8 years, it doesn't have a role, but we routinely do it still. Whatever little amount of growth is left, we try to shut it down.
So before you do the VDRO, are you doing any medial procedure to increase the motion or to get rid of that subluxation?
If the adductors are tight, under anesthesia, we examine and we take him into abduction and see if I'm getting a good abduction and the head is getting contained. I don't do the medial release routinely. I don't do it.
So Salil, I'll just interrupt and ask a question here.
Yeah.
Somebody wants to know whether hip distractors to reduce the hip or create space early or late in the disease. What is your opinion, and do you think it works?
Yeah, so I personally have never used hip distractors. I've looked at all the studies that have compared hip distractors to Salters. I have some of that data to show later. I personally don't believe it works. I think it's a concept of offloading the joint. With the distractor, the patients are able to weight bear. The weight is transferred around the hip joint, not going through the hip joint. But I think there's so many complications with these patients in terms of pin site issues and maintaining them in the distractor. Again, Mandar was talking about keeping a 5-year-old off weight, trying to keep a 5, 6, 7-year-old in a hip distractor is also a tremendous headache.
Equally tough.
So I
Yes.
think our strategies of containment work in, the vast majority of patients. So I prefer to stay away from the hip distractors. I'd say in the US, Scott Nelson and Sean Standard, and maybe, I don't know if Paley's still doing it because he's kind of stopped talking about it. But there's a couple centers around the US that still consider using it.
Salil, in this case, it seems that there is an adduction deformity to the hip, and the hip
Yeah.
seems a bit stiff. So
Yeah.
in this case, probably, as you said, we should probably do a medial release and get a range back before we do any definitive procedure.
Yeah.
So what do you
Yeah,
do?
I absolutely agree. I think a medial release is imperative, almost an inferior subluxation of this. You're opening up that medial capsule so much to allow the hip to completely sink into the acetabulum. So this was after that medial release was done. You can see how well that head can be contained down. But the amount of varus that would be required to keep that head, tucked in under the labrum. So that's the type of patient in my hands would go for a triple innominate osteotomy. So this is what her immediate post-op looks like. So quite a lot of correction with the triple. I usually put them into a spica cast after this. So for PAOs, I don't use casts. For triples, I think it's important because the entire fragment is completely loose. So spica cast for 4 weeks. And then here she is at 16 months and 30 months. So ossification still continued healing for her, but I think it's a reasonable approach. So we had just looked at our kind of concepts of advanced containment with the triple innominate. This study was in JPO, I believe, a year or two ago. So Stuhlberg's 1s and 2s, 64%. Stuhlberg 3, 26%. We just broke them up separately. And poor outcomes of 10% with mean follow-up of 6 years in these patients. So obviously after the triple, you see some significant radiographic changes, but we wanted to look at to see, so these are some, mostly Dr. Wenger's patients, some of my patients, but done for various indications over time. And you can see how age doesn't really have an effect on the Stuhlberg classification when they're all treated with the triple. You can see Elizabethtown classification, so doing them early, doing them late, didn't have a significant impact on the results, but 80%, 1s and 2s, which is good. And then Catterall, in terms of how much of the epiphysis is involved, 80% with the less involved, 61% with the more involved. So I think it's a reasonable approach. There were some complications in these patients in terms of the pubic non-union, in terms of over coverage and retroversion of that triple. Early on, we didn't really have those concepts of femoral acetabular impingement. So to gain the excessive coverage of the head, sometimes the fragment was retroverted, requiring rim trim procedures. But I think for the more seriously involved patients, it's a better approach than non-operative treatment or some of the other strategies that we'll talk about soon.
So Salil, in this case, in this paper, I think the most important thing which you consider is the involvement of the head rather than the stage of the disease or the age of the disease. Probably contrary to what we usually think about when we manage Perthes.
No, so I think the treatment algorithm that I'm presenting is kind of a work in progress, and it's based on the outcomes that I've seen through published literature as well as our own outcomes. So traditionally, Dr. Wenger was a big proponent of using triple for Perthes kind of across the board. That's why there's patients of all ages, there's patients of all epiphyseal involvement, and seeing how those patients do as well as how they do with less risky procedures. I think I've kind of come up with this staged wise approach. So I think it's a really good procedure for older patients with more involved disease, but I like to reserve it for that particular population than ones that can get away with the femoral osteotomy.
All right.
Salil,
yes.
if I ask, is there anything which might influence your decision to go from the femoral osteotomy towards a triple? depending on the degree of abduction that you need, the amount of varus that you need? Is there a cutoff?
Yes.
Is there a figure that you kind of have in mind when you go?
Yeah, there's not a number, but I kind of showed in that arthrogram image. I think if that tip of the trochanter is starting to go above the joint, so you're pretty much guaranteed to get impingement from abduction of the hip, I think that's where I look to a triple instead of doing it excessively on the femur. Venkat, how often have you had to do a valgus osteotomy to compensate for that excessive varus?
Venkat, you'll have to unmute.
Sorry, I think you're muted.
Yeah. So I'm not done for my follow-up cases, but a couple of cases which were done elsewhere, maybe around 2 or 3 cases I had to do a valgus. Yeah.
Salil, there's a question from Kapil Gangwal. Under anesthesia, if you see that the child has good range of motion, do you still go ahead with your adductor and medial release? And then how much capsulotomy do you do?
I do still go ahead with it because I know that, especially if they've given them paralytics, that muscle is just paralyzed and you're kind of artificially getting that motion. Especially if there's subluxation on the preoperative imaging, I know there's inflammation in that joint. And for me, cleaning out the joint is part of treating the disease. So I would go forward with it. I wouldn't do an excessively large medial release, but just enough to be able to visualize the ligamentum teres, to visualize the synovial hyperplasia that's always there on the inside of the acetabulum. So just I stick a pituitary rongeur in there and clean it out.
Okay. What is the endpoint of your capsulotomy?
The abduction that I get to contain the head. And
okay.
endpoint
And
of the cut.
Do you check for hinged abduction with every arthrogram?
You know, so I think hinge abduction, that's a very controversial question. I think hinge abduction really only happens in the late stages when you have reossification. So if your lateral margin, if your lateral pillar has new bone in it and you're abducting, that's where the hinge abduction
you mean it's
happens.
impinging? Actually, it's actually impinging and creating an indentation.
I think so, yeah. So I think a lot of the medial dipole that you see with regular arthrograms with abduction, I think that's just deformation of the femoral head. That's not really hinge abduction. But I think that's open to interpretation. All right, so finally, these more salvage procedures. I have a couple more cases in this group. So valgus osteotomy, basically just to maintain motion. Valgus plus shelf if you're still trying to, keep some coverage of the femoral head. Joint distraction, fusion, and arthroplasty. So obviously, this is the type of patient with very severe disease, older patients, significant femoral head deformity. What are good strategies for that? So I don't think this is a case that's just a 10-year-old with right side Perthes disease, marked extrusion, stage 3B. So in a salvage state, this was treated with a valgus and a shelf. And this is their 7-year post-op outcome. So obviously, not a fantastic result, but relatively spherical femoral head. So these are the joint distraction concepts. This paper that was recently published in 2012, similar outcomes between the distraction as well as between the Salter and the distraction. So I just think that there's greater morbidity associated with this, and I prefer to not go down that path. And then in terms of arthroplasty with the significant deformity of coxa magna and the larger head, I think total hips can get very complicated too, because you have to really medialize that cup and get good offset to tension the abductors properly. So here's a case who hasn't, maybe back to Mundar. So it's a 12-year-old female now with right hip pain. So not too bad, right? 40%, or sorry, 60% perfusion.
Yeah.
She was actually treated in Cincinnati with conservative treatment because of the not severe involvement of the head. Here she is at 1 year. And when she finally came to us, so she had gone to UCSD for college. So she came to me with hip pain with 18 months of symptoms.
Salil, I think this hip is behaving like a typical adolescent Perthes. The child came to you probably at almost the end of her skeletal growth. just the cusp of skeletal maturity. She was a 12, 13-year-old female.
Yeah.
And I think the hip has progressed, the disease has progressed really very badly with the complete involvement of the head.
Hmm.
Uh, Looking at the way the head is, I don't think that there is any good solution to it as of now. We can do a image additional imaging in the form of an MR with a CT just to look at how where we are. But I don't know whether we can salvage this hip in any way.
Yeah. Yeah. So here's her MR. Quite significant cartilage damage, both on the femoral side as well as the
Yeah.
acetabular side. So my early thoughts were maybe some sort of osteotomy to
Correct.
bring this portion of the head back up.
Yeah.
But that MR was pretty disheartening in terms of large cysts, even in that weight-bearing zone, and terrible cartilage on both sides. So
Yeah. So going back, Salil, can you go back to the
yeah,
earlier at the time of the first presentation?
yeah.
So at the first presentation, would you have done something differently when she presented at Cincinnati? Would
Yeah,
you have done something at 12 years in a female with this X-ray?
that is a great question. And if I did anything, would it have changed the course?
Exactly.
So it's that whole concept of creeping substitution here. So no matter what you do to revascularize, are you going to
So,
be able to preserve that?
so there are a few questions here. Adolescent
Yeah.
Perthes, would you think of epiphyseal drilling and BMP or distractor again here?
Yeah, so I think that's the direction that
People who
most.
have gone to Pali are very fond of distractors, so you have to.
Yeah, no, I understand. I think that this might be the best indication for that treatment approach, because I don't think we have anything better to offer. I think the injections of the epiphysis are kind of the cutting edge, low invasive options that you could give patients to see if you're going to be able to preserve the head. I personally don't think that even with distraction and injections, you're going to get a fantastic result in this patient, but I think it's better than doing big osteotomies that will likely not change the natural course of this disease.
Correct, correct.
My
So
personal opinion.
you would probably like to retain the anatomy for a hip replacement later and treat
I think so.
the pain.
I agree. Yeah.
Right.
Mander, where are
Yeah.
you
So
on that?
So is there a
how
role for head reduction? When do you do head reduction? Or you're going to talk
So I
about it
think
later?
yeah, so I think I haven't found the best patient for it as yet. I need good cartilage, obviously. I need a head that can actually be turned back into a sphere. And I need an acetabulum that hasn't secondarily modified itself to accommodate a big elliptical head, where now if I shrink it down, it's going to be a little pebble instead of a huge cup. So I haven't found the right patient for it yet. I don't think this patient would be the right one
Yeah.
because of the amount of cartilage damage. But I'm going to show you one a little bit later where
Okay, okay.
others could have considered that.
So how soon do you or a joint replacement surgeon at San Diego consider to go ahead and do something in a
So it's based on symptoms, because based on this MRI, there's nothing to preserve, right? There's no cartilage. I could continue injecting her with steroids to keep her symptoms at a
minimum.
minimum. I
Yeah.
think in India, it seems like maybe you can just send them off for a while and
Yeah.
like go live in the wild for a little bit, and if you come back when it really 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 bothers you. But
Yeah.
here I think because there
Right.
is
So
such an
what about
availability.
osteochondroplasty?
Yeah, so again, later I'll show you one case. I don't think that's a great option for
Yeah.
this patient because of the extent of involvement.
Yeah. Okay. Okay.
So anyway, so she ended up getting a total hip. So we do these with ceramic on poly. And this is just a DePuy implant for. So alternative methods with drilling, medical treatments, Morshire osteotomy, head reduction, allograft. So I think there's some good data for epiphyseal drilling now. I think it's very, it's kind of, it's not long-term data, obviously. There's been a arm within the International Perthes Study Group that started looking at drilling, especially in the older patients, to see if it's going to change the resulting, preservation of the head. So I think there's still more data to come. This is the review article that I'd mentioned in Core, published in 2012. There's only 3 level 4 clinical studies at this time, but lots of experimental data and animal studies that show that bisphosphonates can slow down osteoclasts. But again, until you show me in a patient that it's not going to block VEGF, I think it's difficult to go down that path. So injecting bisphosphonates as well as BMPs, there was complications of heterotopic ossification in the pig model, but it definitely, you can see the structure of the trabeculae are much better in those patients or the pigs that were treated with it. So alternative treatments for coxa breva, I think this Morshire osteotomy is extremely powerful way of approaching this disease, or the head reduction osteotomies. This is Paley's description where he removes the necrotic fragment and then slides that lateral head back into position. You saw that acetabulum in that drawing perfectly fit the head, which I don't think is true for most patients. So this patient, maybe Manoj again, we can address this kid. So 9 years, male, bilateral Perthes. He was treated conservatively by Dr. Mubarak here. So 6 years later, this is how he looked. You know, the head healed relatively well. And this is the secondary deformity that this patient has. So this might be a good patient to talk about the different approaches for valgus, relative neck lengthening, head reduction osteotomy. What's your approach? How do you deal with this child? Main symptoms are decreased motion and impingement. Sorry, Manoj, I think you're muted.
You have to
Yep.
unmute your mic, Manoj.
Yeah. Sorry about that. So this looks like a large head, which is and with a relatively mismatched size between the acetabulum and the femoral head, with a very high riding trochanter. So I suspect that the abductor lever arms are not working very well. So this is one where I would kind of, if I could go back to the X-ray, yeah.
X-ray, yes. Mm-hmm.
Yeah. So this is somewhere where I would consider definitely a relative neck lengthening. So I would want to kind of, through the safe surgical dislocation approach, get the neck lengthened out, abductors distalized, and concurrently an osteochondroplasty. I didn't see a specific area of necrotic segment, so I don't think this is a case wherein you would want a head reduction as such. But I think if you can take off some of the femoral head from the osteochondral overhang on the anterolateral aspect, that should kind of get you a good range of impingement-free motion. So relatively getting to a safe surgical dislocation with osteochondroplasty. That's the way I would go.
Yeah, wonderful. Yeah, so this is the head. I think that the secondary changes in the acetabulum are very, very common, right? I think this disease obviously doesn't just affect the epiphysis, it's changing the cartilaginous enlog on the edge of the acetabulum. So many times when I see a patient with a big head like this, they have a big cup to accommodate. And so I think that's why this concept of just shrinking down the head alone when you're leaving a large acetabulum, even if you do a PAO down the road, doesn't make a whole lot of sense to me. So similar procedure to what Manoj was saying, I did do the Morshire to get length of the neck as well as to gain length in the limb because the patient was about 2 centimeters short. But it was a Morshire with a Watson-Jones approach to do the osteochondroplasty in the front of the neck. So I didn't do anything to the acetabulum. The head is actually accommodated pretty well within the acetabulum. This immediate post-op. This is 6 months post-op. You can see on that frog view. I think the head is preserved in 13 months post-op. So trying to reconstitute the proximal femoral anatomy. Do you think anything will need to be done to that acetabulum, Manoj?
I think it looks reasonably well contained. I mean, if the patient is asymptomatic, I would keep a watch on it. I don't think there is any significant mismatch there. So yes, it looks slightly dysplastic. It's not the anterior and posterior walls are not as well covered as you would want it. But if the patient is asymptomatic, I wouldn't do anything. I would just wait and watch.
Yeah.
So Salil, there's a question. Where does head reduction osteotomy fit into your algorithm? Or there is no role till the head heals and reossifies?
Yeah, I would wait until you've gone through the stages of Perthes. I think you need to have a healed head. You need to have a central area of necrosis, and you need to have an acetabulum that's not excessively large.
Okay.
So that's
And
why yeah.
there was one more question that avian, because of hemoglobinopathies or sickle cell, which behaves like adult avian or adolescent avian, what would be the end of what would be your approach? Is there some different approach, or you would treat it like any routine Perthes?
No, with the systemic disease, you know it's gonna just keep occurring again and again. So I've done drilling for those patients. Um, I've done systemic bisphosphonate treatment for those patients. They're all just kind of grab bag procedures. Cord decompression with BMAC and bone grafting. I've tried. Uh, there isn't a great approach, and I think that's the region of pediatric orthopedic treatment that needs a lot of work to kind of figure out how to approach those patients with AVN. So unfortunately, total hip arthroplasty is in their future.
There's one more question from Patna. What is the endpoint of distalization of the greater trochanter when you do a neck lengthening or bring the trochanter down?
Yeah, so when you do that neck, oh, so you're saying with the relative neck lengthening, I like to put the tip of the troch at the level of the center of the femoral head.
Femoral head. Okay.
With this femoral or with this Morsher procedure where you're actually distalizing the shaft,
Okay.
you're taking out that central prominent portion, so kind of this portion of the greater trochanter, putting it laterally, and then
Right.
then that greater trochanter just fits on top of that piece.
Yeah.
So,
Okay.
but that's kind of what you're aiming for. You have to be careful when you look at your fluoro shots intra-op, because if this leg is too abducted, adducted, that relationship can kind of change on the table. So.
Right. Okay.
So
Somebody
if
is
I may-
asking, would you do a PAO with the same at the same time for this?
Yeah, that's what I was thinking, whether or not this patient would need a PAO later. But I think I like Manoj's approach, and it's already a very big procedure with a lot of moving parts and bony fragments that need to heal. So my approach was to see how this healed, how their pain was, and if they had any persistent symptoms, then address the acetabulum.
Salil, what was your reasoning
Okay,
behind doing a Morsher versus surgical dislocation neck lengthening?
Yeah, so a couple things. So I didn't show the full length X-ray, but usually when you have so much coxa breva and vera for the hip, you have a lot of valgus at the knee in terms of compensation. So one was the alignment, the mechanical alignment, and the other was the leg length discrepancy. So this gave about 16 millimeters of length. Yeah, and it actually corrected the knee alignment also by changing the angle at the hip. Yeah. Okay, final case, 8-year-old male, left-sided involvement. This is him healed, so 7 years later. So Venkat, if you want to address this. So this might be a head reduction candidate perhaps, or what do you think?
Yeah, and the present complaint is pain, right?
Say that again?
Salil? Yeah, what's the patient complaint now?
Clinical symptoms.
Yeah, so symptoms are, so pain, he's a basketball player, so he has pain when he's playing basketball. He does have positive impingement, but I think a lot of these patients do, and his motion is actually relatively good. He has about 40 degrees of abduction, which is symmetric. So for the most part, healed well from his Perthes, little bit of proximal femoral deformity, obviously, and then the central area of necrosis.
Yeah, the head doesn't look like too huge when what we typically see in a Perthes scenario. It's not a real coxa magna, though it's definitely there is some coxa magna, and we don't see many patients in this typical with complaints. Most of our patients with this X-ray will be asymptomatic, at least in our setup. So if the patient is symptomatic, I think we'll have to find out what is the cause for the pain, and if the real head is impinging, probably head reduction osteotomy may be an option. I'm not a surgeon with a lot of experience with that. I think Mandar has done a couple of head reductions. Manoj?
Yeah.
I think what Venkat said was very good. Was what were the symptoms? So if he has symptoms during playing basketball, do we have something in an armamentarium which will make him have no pain while going back to basketball? So even when we are doing a head reduction osteotomy, are we going to allow him to play basketball after that? Is something which we need to think of before we think of any surgical procedure as extensive as a head reduction osteotomy.
Mm-hmm.
So here, if as Venkat said, a child with such a good head in an Indian scenario may probably not have any symptoms. He may, if we tell the parents not to send him to a high impact sport like basketball or something, they will probably say fine and get on with their life. But I don't know. So I think
is this such a good head with such a large area of
yeah.
necrosis?
So probably this may be worthwhile to do as if you just look at the image and the exact indication for doing a head reduction. This may probably fit into that, but probably the clinical symptomatology does not make us do such an extensive procedure for a pain which comes on with high impact sports, and he may not have pain when he's probably doing his normal day-to-day activities.
Mm-hmm. Mm-hmm.
So
pain at rest.
Can you go back to the X-ray? If you look at the joint, it is so congruent now.
Yeah. Yeah, I agree. So that's why head reduction just doesn't make sense to me, because you're taking such a nicely congruent joint. I think just treating that area of necrosis with an allograft.
Yeah.
So basically took out this, it was 25 millimeters, so a pretty big plug, just drilled the base of it, packed that cyst that was present, and then a single allograft plug.
So that's a nice alternative to doing a reduction. You treat only the necrotic segment.
Yeah. Yeah. So 6 months out, and this is in 2 years out. So that area still, I don't know, doesn't look fantastic to me, but really he's back to playing basketball. And so that's another thing. Do you put your patients through these procedures, but then tell them to not do the things that they love to do, right? Like, I mean, it's just
absolutely,
it's really hard to have that conversation.
Right.
Agreed.
If I may ask here something, Salih, in
yes,
terms,
please.
I mean, this is not at this stage. We do have a lot of questions early on, parents asking about activity restriction. What is your take on activity restriction? Is there a certain type of sorts? I'm not talking about this late stage or this particular case.
Yeah.
About early on, when do you have an approach where you say, okay, they should not be doing certain sports for a year and a half, 2 years or anything? Is there anything you have?
Yeah, so I have restrictions until the patient enters into reossification. So I feel like when that lateral pillar has new bone in it to support the weight, I release those restrictions. My restrictions are basically only swimming and home exercises and that abduction brace at night. So anything I can to...
Did you fix the allograft is one of the questions which has come in.
No, so this one was press fit because it was a very central location that it had a good fit.
Okay.
There are ones that were more edge loaded that I put a central one screw, Accutrax, the headless screws.
Okay. And why didn't you distalize the trochanter at the same time is a comment.
Good question. I should have. This was 2 years ago. I would have done it differently. So I did a Z shaped greater troch osteotomy to help for healing. Yeah, I should have distalized it.
And some Anirban is asking why did you do the light bulb procedure?
The snowman light bulb, the two allografts, I'm assuming.
Must be.
Yeah, so so I got the whole femoral head allograft, so it was big enough to fit this contour. But I think that's a very reasonable option because oftentimes with such large lesions, it's hard to match the sphericity of the head. So putting 2 or 3 plugs even is a good option.
Yeah. Okay. So I think you are summarizing, and then we can go on to cases. We
Yeah,
have 30 more
perfect.
minutes.
Perfect,
And
perfect. So,
Salil, we would like to inform you there are 1,600 people logged on.
wow, wonderful. Wonderful. So take home points, I
Because it's
think it's
good to have a feedback. You don't know how many people are listening.
yeah. Yeah. So disease etiology, I think hypoxia and strain, like keep that in mind that there is some mechanical effect there as well. Containment strategy should be based on the stage of the disease, the age, the severity, non-operative treatments, as well as this clock algorithm. I think importance of study group for these patients, because each individual surgeon will only see 30, 40 patients. So it's really important to collaborate results. I wanted to highlight this organization too, Perthes Kids Foundation. So this man here has kind of gone around the world, and I think India is one of his next destinations to bring kids with Perthes disease. So what Mandar was saying, some of these kids are my patients, and I had put them on restrictions, but when I went to this camp, I saw that they weren't following any of my restrictions. So I think it's good to, understand the disease from a patient's perspective and kind of
Right.
fine tune your approaches for that. Perfect. Thank you, guys.
Thank you, Salil. That was wonderful. So I think Mandar has a presentation where he has put up some cases. We'll have a case discussion and we'll wait for more questions.
So I'll
But
stop
I
sharing.
think even 2020, as we deal with so many options in Perthes, we have learned with experience that it's not bad to be conservative. That's number one. And too much of virus really doesn't make the patient happy, though you might have a better looking X-ray. They limp so badly that the parents curse you lifelong. And maybe Mandar will highlight a few more points. So over to you,
I
Mandar.
think Sandeep,
Yeah, Salil.
what you said in terms of there's no harm in being conservative, I think there is harm in being conservative for too long, because I've
Too
definitely
long, yeah.
seen patients that were followed conservatively and then they've healed in a terrible position, and that really limits what options you have down the road. So in terms of being a little bit more aggressive with containment, it's a fine balance, but I think there is some benefit to that.
So you think the perfusion MRI would be a good tool to guide you to when to wait and when to operate?
I think so.
Okay. Mandar?
Great. Yeah, just one second. Yeah. So Salil, what we'll do is we'll probably have you take the first shot, and then we can have the panel answer the questions.
Yep.
All right. So this is this first case. We have an 8-year-old boy has right hip pain with limps in 6 months, has not taken any treatment, and has a mild antalgic gait, not much of pain. His internal rotation is terminally restricted. His abduction is good, about 40 degrees, and flexion is full. He is a young, playful child, and these are his X-rays. This is July 2015 when he was about 8.5 years old. Salim.
So his abduction is restricted, you said, at 40?
No,
There's a difference?
No, internal rotation is restricted. His abduction is full.
Oh, full abduction. Okay.
Yeah, almost 40, 45 degrees. So he's doing well.
Yeah.
Almost no pain.
Yeah.
Comes with a mild limp. A
Yeah,
typical
so
kid.
just starting to see, early sclerosis, decreased size of that epiphysis. I mean, obviously, I would do an MR arthrogram or a perfusion MR for this patient just to see where this disease course is going to go, and I would continue with stretching and home program and any way to maintain that abduction that he has.
All right. So how often will you see him again?
I see him every 4 months.
With
How often do you guys see him?
Yeah. So whenever the child comes back, so I'll show you what happened to this. So Venkat, if this guy comes to you at Ganga,
Yeah.
so what are you going to do?
Yeah, same. Conserve. I'll explain the parents and ask them to come back after 4 months. I see them every 4 months.
Okay. So at 8 years, so do we? I mean, we are all followers of Dr. Benjamin Joseph, sir. At 8 years, is your plan going to be?
Previously, I used to do a lot of, what is called prophylactic containment, even though there is no extrusion. These days, I wait till there is some sign of extrusion before I do containment.
Okay. Manoj, sir, what is your plan for this?
So again, I have moved away from what Venkat is saying about being too early, going too early and too heavy on containment.
Okay.
I would keep a close watch on this because this can quickly deteriorate in front of your eyes in terms of the loss of abduction or extrusion. Both of those would be worrying signs for me. So I would follow them up at 3 months, because they
Okay.
change very rapidly. I would
All right.
start counseling the family about the need for containment very quickly.
Yeah. So, all right. So let's summarize. So this is probably stage 1A. His age is more than 7, has good range and no extrusion. So if you look at what we have been taught, this was July 2015. This at that time I had advised a VDRO, but whenever a child who has no pain, we advise a VDRO, there's always someone next door who will say, why are you doing some surgical procedure? And they went away. His next follow-up was a year after that. Again, as I told you, it doesn't matter what we suggest, it matters what they come to us with. So they came after a year or so with when he was 9 years old. This is October 2016. He had a bit of a restriction of range of motion. His abduction was about 30 degrees. He had slightly more limp, though he was doing all routine day-to-day activities. So what will you do, Salim? He is now 9 years old, October 2016.
Yeah, so despite having relatively few ADL restrictions, I think I need to intervene. This is where just continued conservative doesn't make sense to me.
Exactly.
There's subluxation of the hip, Catarrhal 3, 80% head involvement, metaphyseal cysts. This is not going to be good if you just leave it alone. So I would do medial, adductor lengthenings, medial capsulotomy, Petri cast for 6 weeks, and then depending on what that arthrogram shows, but most likely a triple in this case.
Perfect. All right. So as we said, it's about 2A, 2B, age again more than 7. Fair range, abduction is restricted, is just about starting to extrude. And as I think you said, I first advise range of motion improvement by rest and medial release and Petri cast, followed by what I would have done a VDRO. But again, the parents were not willing.
So
you can see how that.
Salil, I'll just interrupt here for a moment.
Please,
a lot of people wanted to know the details of your medial release, including extent of capsulotomy. So approach, incision, what all do you release? How much capsule? When do you stop?
Yeah. So medial incision about 1 centimeter off of the groin crease. Take the adductor longus. Take almost all of brevis. You can see the obturator nerve, so protect that. Release brevis. Check the abduction and flexion of the hip for checking gracilis. Most of the time gracilis is tight, so release that. And then visualize the medial femoral circumflex vessels on the capsule. Start my capsulotomy medial to those vessels, and then sometimes lift up the vessels and carry on the capsulotomy underneath, where I have a good visualization of the femoral head and ligamentum teres. Clean up the synovium that's inside of the joint and allow complete abduction of the hip, so you can see that femoral head come down, poking out through your capsulotomy site. So I don't have a good way of quantifying how much of that capsule you're releasing.
So
you're
if it's
releasing enough to allow it.
is 360, are you releasing about 70, 30%, 40%, 50%?
40%, yeah. I think 40% is a reasonable.
Okay.
Yeah.
Okay. So that would be.
And one more question. Do you always stage it if you have to do a VDO after the medial release? Do you always stage it, or do you do the same sitting?
I do stage it, and I think that's more just what I was taught. So I don't know if that makes a huge difference, but I think it does help to decrease the inflammation, allow the motion for that hip joint before you go back to do the femoral or the bony procedure.
So yes.
My issue with this X-ray, so his whole hemipelvis is externally rotated, right? You can see that with the ischial spine sign, the obturator asymmetry. So this fairly good range, basically you're even just trying to keep him flat on the plate, and he can't do that because of how tight his hip is. So I don't think, I don't think his motion is good.
Good, yeah, it's a stiff hip.
So coming back to what Venkat asked you, so do you give a Petri cast for probably 3 to 6 weeks? How much?
6 weeks. 6 weeks.
And
Yes.
then you have a time period of the cast for a few weeks and then stage
I
him back,
don't,
or you do
because
it?
no, I don't. I do it at the same time.
Okay.
Yeah. So the groin is all open in a Petri, so I don't think that skin is that dirty. And if you're going to do a femoral osteotomy, I have a Gore-Tex, Aquacast material for the cast, and the skin is usually in good shape.
All right. Perfect. All right. So coming back to this case, so this is now October 2017 when the parents said enough is enough. Abhi, now you do something about it. So we have gone to all the bone setters in town, and now we are back to you. And now what do we do?
So what would you offer now, Salil?
Most of our patients will be like this, Salil.
That is why.
Perfect. I mean, so maybe like the medial side of the head is reasonable. So kind of like the far along 12-year-old that I showed you. This might be good for a valgus osteotomy, and then maybe flexion, depending on what the frog looks like, and then a big osteochondroplasty to take off the bone on the lateral side.
There. Okay, that's one option. Mandar,
right. Yes,
what did you
Sandeep
do?
sir, what will you do for him?
No, like we said earlier that this whatever we do, we are in stage 2. That is, we are salvaging it. We are not
Stage
going
3.
to make this.
Stage
We are
3.
not making. If he has a decent range of motion, which
Yeah.
is a prerequisite, you try to cover the head, whatever is uncovered, by doing a shelf.
Yeah.
And here there is a question: is the shelf better or a triple osteotomy? Somebody has asked, how do you compare shelf versus a triple? Is it only the extent of surgery?
Extent of disease. I think you can rotate a triple much better, and then obviously the triple is bringing acetabular or articular cartilage over the femoral head, versus a shelf is just using the capsule. So
Okay.
I
It's
think
pseudocartilage versus cartilage.
correct.
Right.
Okay.
Salil,
All right.
would you do a triple on this? Salil?
No, I don't,
No.
because I think containment is gone. He's in
Gone. Right.
late stages.
Yeah.
So he's on that, third remedial phase.
Remedial.
Right.
So I think just valgus osteochondroplasty.
Okay.
All right.
So,
Venkat, what will you do? All right.
I've seen the X-rays, Mandar.
Yeah. Okay. All right. So what I did was, so unfortunately this video is not working. So his head was as expected, quite big and not going in. So what I did was a shelf acetabuloplasty. I do something known as a secured shelf. I put a small plate, a recon plate, which is bent so that the graft doesn't wither off. So this is the immediate post-op. Put a lot of cancellous graft over it. This is at 3 months. The graft is still there, and this is a 2.5-year post-op follow-up. So I'll say it's about the Stuhlberg 3, which looking at the previous X-ray, I think was a fair result after everything which has happened.
I think a valgus at that same time would have been wonderful, because now you won't have any hinge abduction, or the pinching. Abduction impingement. Your hinge abduction, I think this is a good case to show that after you have ossification of that lateral pillar, like you showed on that pre-op X-ray, that's where that lateral bone can pinch against the acetabulum and actually cause the joint to hinge open. So do you think it's still subluxated, lateralized, hip center is lateralized?
Yeah, there is still some amount of lateralization of the hip center, but again, probably looking at the X-ray when they presented in 2017, this is a fairly okay result.
It's good. It's great.
You have a further follow-up, Mandar?
No, this is the last one. This is again those kids who come when they want.
Okay. So would you have done a trochanteric epiphyseal disease?
Yeah, so that is one thing which, looking at this X-ray, probably I thought that I should have done probably drilling, put a screw across through the trochanter, probably to decrease the amount of trochanteric impingement. But again, as Manoj sir said, that procedure is an extremely unpredictable one.
Right.
So I don't know whether I would have made any difference in it.
Right. But I think even then you now at least have an oval socket and oval
sort of,
head.
Yeah.
Sort of. So
It's
it
congruous.
would last congruous and it would last better.
So again, as there has been a few some literature about this. Another similar case with an extruded head. This was one of the first cases which I did with Dr. Alric. So this is a 6-year post-op. Again, a Stulberg 3 hip, but I don't know. I think a shelf which in our scenario we use for the heads which are extruded and in which we can't do anything else is what we reserve our shelves for. I'll go to the next one.
Yeah, yeah.
So this is a
I think
10-year-old boy.
seeing these
Salil.
outcomes now, do you think it's worthwhile just distalizing the troche at the same time?
Exactly.
Not even
Probably I
trying to
would have
close
done.
it, because I agree. Yeah.
So there is a question, Salil. Would you do prophylactic containment in older children?
Yeah, I think it's it's a difficult question. Sometimes prophylactic containment won't preserve the head, like in that case that completely collapsed. So
Right.
I think
Best result for younger kids.
I think so. I think it's ideal for younger kids. It's hard to say justify it in older patients.
Okay. Okay. Let's go to Mandar's second case.
Yeah. So this is a 10-year-old boy, has a right hip pain since 4 months. Again, similar case, mild antalgic gait, internal rotation terminally restricted, and has an abduction. So this is a very old X-ray. So Salil, what will you do? This is a 10-year-old boy, big hefty chap. What will you do for him?
10-year-old boy, pretty far. So still in 1B, still early, hasn't started to fragment yet. But it's already starting to get larger. So I think, either arthrogram, either VDRO or an acetabular procedure, like a Salter maybe.
So so here this child thankfully agreed to our plan. We did a VDRO. That time we used to put them on a Petri cast post-operatively. So this is at 2.5 years. You think this is fairly okay?
Yeah, I think that looks good.
Yeah. So 3 years post-op, they came. I was quite surprised that they came because I had asked for an yearly follow-up. He's doing fine for the right side, but the left hip then started complaining of pain. So he's now about 12.5 years old with this hip. So he's now an adolescent, a big chap with bilateral Perthes. So
a question here: how often do we see Manoj and Venkat bilaterality in Indian patients?
Yeah,
I would say like less than 10% in my practice.
Yeah,
it's about 20% for us.
Right.
Closer to Venkat's numbers, I would say, for me.
Yeah, we don't see so many
Exactly.
bilaterals. So would you suspect if there is a bilaterality, a hemoglobinopathy or some other disease, primary metabolic bone disease?
Not always, especially when it presents so far apart. If they initially present with both hips that are involved and in the same stages, then I have a workup for epiphyseal dysplasia and mucopolysaccharidosis and all of those differentials.
Yeah.
But this is pretty common for
Metachronous
presenting in different
involvement in, so it's typically an idiopathic kind of Perthes which presents at different stages at both sides.
Yeah.
So what
are you gonna do? You're gonna do. Sorry, go ahead.
So one of the cases which we had, which had a metachronous presentation, again, apart from everything else worked up, showed deranged thyroid function test. I don't know how much hypothyroidism is linked with that, but not enough to warrant treatment. But that was something again which was new to a deranged thyroid function.
Okay.
All right.
So Mandar.
So I probably gave him. He's about stage 2B. 2A, 2B. Age was 12 years. So I was scared that he's going to behave like an adolescent AVN. Had no extrusion. I gave him a chance and did a VDRO. So this is 1 year post-op from the left side. And this guy sent me his images on mail. So this is 9 years post-op for the right side, 6 years of the left side, and this is his video which he sent. It's big chap, is now about 18, 19 years old.
Yeah, very good.
So we'll go to the next one.
Panel, do you
Yeah,
routinely
yeah.
remove your implants? What's
I'm
your
sorry?
take, Salim, on that?
I'm sorry.
Hardware removal.
Hardware
Yeah.
removal, Salim.
So I wanted them to come back for implant removal, but one thing led to another. Then he had his 10th and then his 12th, and
Okay.
Yeah,
Okay,
I
so-
would.
hi to me
I
in
would.
between. Yeah.
So I think last case, Mandar.
Yeah, I think so.
So that osteotomy in the subtroch region, you don't have problems with putting it so far distal?
So I think it started off just where just below the lesser trochanter, and so that the first screw is through the greater trochanter.
Okay.
So you agree to VDRO at this age, Salil, is one question.
Yeah, I mean, it was in the early stages again that you're catching it. So preventative
well.
treatment. So yeah, either
Okay.
salt or
Okay.
VDRO, that would make sense.
All right. Okay.
But it's
And
older
that-
stage, older age. So yeah.
Yeah, so this is an older chap, 12-year-old male child, has limping since 8 months, unable to sit cross-legged, has a flexion deformity with further flexion up to 130 degrees, has a fixed adduction deformity and fixed external rotation deformity. And this is the hip. I unfortunately could not upload the CT images. It's a big, huge head with a central necrosis. Yeah. So am I coming to?
I know where you're going with this.
Yeah. So the last part of the talk. So are we going to discuss that?
Yeah. So yeah, I mean, so there's a couple different options. Osteochondroplasty. You could do femoral head allograft for that central necrosis. You could do head reduction. So again, in my hands, just reducing that head and leaving it in that large cup does not make sense. But
yeah. So I think what you said was absolutely right. That when you do a head reduction, then it becomes a very small head in a very capacious acetabulum, which has become capacious because of the coxa magna which has developed. So in the recent papers, what they have described is doing an acetabuloplasty with it, something like a small Degas acetabuloplasty, and so as to decrease the volume of the inclination of the acetabulum, so as to cover the head better. So that is what I have done here. As you can see that there's a large central necrosis right here. I've done a femoral head reduction and done an acetabuloplasty. So it's important to know that we have putting this screw because this portion of the femoral neck is extremely thin. So it is said to put this screw in just prophylactically to prevent femoral neck fracture. So this is the
how do you plan for that surgery? Like in terms of how much to resect? Do you have 3D printing or anything?
So here I had done just a CT, not a 3D printing. We had a very good image with the 3D printing, 3D reconstruction, and so the typical indication is that it should be having just a central necrosis, and the peripheral zone of the femoral head should have quite good cartilage, which again, as you said, is extremely rare to find, and this was a fairly okay candidate for doing a femoral head reduction. And I did a small Dega acetabuloplasty so that it remains in. Otherwise, it's a very unstable situation at that time. So Venkat, would you have done the same thing?
Yeah, looks pretty good, Mandar. I am not sure whether I would have done the same thing because I have not done many head reductions. And I do not know how much you will be able to turn down the acetabulum with your Dega, but your X-ray looks pretty good.
Yeah. So this is
nice.
This was just 6 months back. So this is a 6 months post-op X-ray. Looks fairly okay. I'm just waiting to see how he does in the long term.
How is his range?
Range, his flexion surprisingly is a bit restricted, only about 80-90 degrees. He is improving in his range. We are putting on a good therapy regimen. Let's see how he goes.
Okay.
Right.
Okay. So there's a question, Salil. Okay, you want to finish this first?
Yeah, so this is just the brief description of the femoral head reduction. So this was what was described earlier, and then Dror Pele has then modified it by putting this single screw just to hold the femoral neck in place so that it doesn't fracture
Yeah,
with
now
two
he has
headless screws.
modified the technique also. The cuts are different from Palace now.
Okay.
New edition book.
Yeah.
Yeah. Anyway, so these are the films on his in his article. All
Okay.
right. So do we have time for
So
one small case of Venkat or?
no, one question which has come up was for Salil was, can you explain a bit about valgus osteotomy with osteochondroplasty?
Yeah, so the concept of valgus is just a salvage procedure to increase your abduction of the hip. And if you have a preserved medial superior or the anterior medial portion of the head that's intact, you can do a flexion valgus to put that portion of the head into the weight bearing zone. And then the extruded degenerative portion of the femoral head that then slides out of the acetabulum, you do an osteochondroplasty to remove that to be able to maintain flexion internal rotation.
Right. Okay. So Mandar, you have another case?
Yeah, a small case of Venkat. I think Venkat can take
Venkat,
It's
over.
actually a routine case here. If you don't have time, it's fine.
We have 4 minutes.
Okay, we can run quickly. The age is, it's a typo. It's actually a 6.5-year-old boy who had pain and limp for 5 months. This is the initial X-ray.
Okay.
Salil, you can see it was earlier in my career. So he presented with this X-ray to me. Salil,
Okay.
can you just tell
So
what?
7-year-old boy, what would you do, Salil?
7-year-old, very severe involvement. Is that new bone forming laterally? Is this late in the disease? Or it's
No,
hard to.
the symptoms are there only for 4.5, 5 months.
4.5, 5 months. Okay.
So I presume that it's still in 1B without
Yeah.
early fragmentation even.
Yeah. So same concepts of maintaining motion and then looking at either VDR, maybe VDRO, but there's subluxation of the hip, and it's. I think it's further along than it looks. So I think triple, but we'll see how you do on your initial arthrogram.
Like, yeah. I don't have the intraoperative pictures. I think this was in early part of my career, even before my fellowship. It was so I had no clue, but I took him for evaluation under anesthesia. I did an arthrogram, and this much of virus was needed to contain that hip. So though I had hesitations, but I did the virus. I got a reasonable containment. Sandeep, what do you think? Is it
too much of virus? Yeah, I would. Today I wouldn't do this.
Okay.
But again, like you said, it was earlier in your career.
So today, if you are treating this, so if you need so much of virus to contain
no,
that hip.
first this patient I would do a Petri cast and medial release and get it reduced first.
Okay.
And get that range first, and then on arthrogram evaluate is it containable or not. And if I feel my varus exceeds 25 degrees, I'm going to do a shelf. Otherwise, I'll do a varus after range of motion is back.
Manoj?
I mean, we've all done that degree of varus long time ago. There's no doubt about it. So I agree with Sandeep. This I would do a shelf. Probably now, listening to Salil, I would add a more extensive release to kind of seat it in.
Right.
Yeah.
And that,
okay. So anybody for varus with shelf combination? No? Have you done any? I've done for a couple of cases like that. Mandar?
Yeah, so probably not. I'll probably do as Sandeep sir said, do a medial release with the shelf. I'm not going to say anything more because I've seen the case.
Okay.
Okay, let's go ahead.
Yeah.
Okay, this is 4 months post-op. So I didn't put the in-between X-rays. This is 1.5 years. Yeah, maybe 1 year, 2 months.
Is there anything funny going on here?
Was there infection or second avian hit?
Nothing. I mean, I don't know what is happening. There is no infection for sure. I don't know whether it is a second hit avian. Salil, what do you think?
I think it's completely fragmented and it's just delayed ossification. So I think I would just continue watching it.
Yeah. Venkat, you have been muted. Yeah.
No, I'm just hearing a ringtone. I don't know whose computer is it. That's why I muted mine.
All right.
So this is like 1.5 years when we removed the plate, and just as Salil advised, we just kept on observing the child. What do you? This is 2 years.
Where's the greater trochanter? Is it?
It's missing.
So trochanteric epiphysodesis has worked to the hilt.
Extremely well.
It has now disappeared. All right. So this is the final X-ray. Yeah.
Shit has hit the fan now.
So this is like he came last May, 2019 May. He's not having any symptoms, but he's having shortening and a little bit of a limp. No pain. What do you think, Salil? Where is it heading to?
I think it's healed relatively well. There's a little necrosis there still. The trochanter seems to have appeared. I think it's coxa breva and a large head. And, when he becomes symptomatic, I would just distalize the troch and osteochondroplasty.
Yeah.
Yeah.
Okay. So I'm just keeping him informed that he might get pain, and I'll ask him to come for a yearly review.
Yeah.
So,
yeah. Perfect. Sandeep sir, you want to summarize or?
And make final recommendations. What for young kids? What investigations and early surgery? What in the middle age and what in the salvage or reconstructive procedures?
You want me to make those recommendations, you said?
Yeah. If you can just summarize the whole thing.
Summarize the whole thing again. No, so I think trying to catch it early obviously depends on when the patient's presenting. I think perfusion MRI is really helpful to quantify the amount of epiphysis that's involved and try to predict where the disease will go. Before there's deformity in the head, I think preventative maneuvers to contain the head are useful, such as VDRO or Salter. Once later on in the disease, kind of the middle stages would be more advanced containment with triple or with varus and acetabular procedure. I think varus and shelf is a great option. And then remedial surgeries, once the head is healed and there's proximal femoral deformity present, kind of more adventurous options such as morsure and femoral head reduction, and FAI surgery is warranted. So.
Perfect.
Thank you. Sandeep?
I think we are waiting for Sandeep sir.
Hello.
Yeah, Sandeep.
Yeah.
Yeah.
So he gave a nice summary. Yeah.
All right, Mandar, you
Yeah,
you can close out the session.
I'd like to thank Salil for this very exhaustive talk and very great cases, and like to thank Sandeep sir and Venkat from Coimbatore, Dr. Manoj Padman from Delhi, and of course Neeraj, who was doing all the tech work here on behalf of Ortho TV, and we had Dr. Taral Nagda also on the panel. Thank you so much.
So Neeraj can give us a feedback of how many people have seen this webinar.
I'll just check and let you know.
So while he checks, we are going one more session on flat foot and foot reconstruction for CP. Probably Dr. Hemadi from Cardiff, UK on adolescent flat foot, and again Dr. Reinhold from Switzerland on CP foot reconstruction. So let's wait for the dates from them. And we'll keep this webinar series going.
Right. Approximately 1,600 plus, more than 1,600 people saw this webinar live.
Wow.
Very good. Thank you.
Wonderful.
Thank you, Salil. Thank you
Yeah,
for
thank
your
you.
time.
Yeah,
And we'll
Thank you so
do
much.
one more later on SIFI or something.
Wonderful. Perfect. Thank you for the discussion. It was great.
Bye.
Yep.
Thanks, Salil.
Bye.
Thank you.
Bye.
Thank you, Mandar. Thank you, Manoj.
Bye.
Thank you, Venkat.
Mandar.